restorative dentistry deals with occlusal concerns, among these are especially restorative dentistry and orthodontics, which focus on occlusion. And every one of us, as a practitioner, should pay a lot of attention to occlusion and to occlusal stability. And today my topic is about the role of occlusion in the stability of orthodontic treatment. And I'm going to talk about the methods and techniques of how to measure the occlusion and how to avoid unwanted tooth movements during orthodontic treatment and after its completion. My goal today is to familiarize you with the anterior-posterior tooth contact analysis procedure, which aims to minimize the number of occlusal contacts that tend to cause unwanted tooth movements during orthodontic treatment and after its completion. And we conduct it with the use of the T-scan digital occlusal analysis, which is used routinely in our practice and which helps us to measure and to count the number of occlusal contacts during orthodontic treatment. And the distribution and the duration of occlusal contacts are the two main things that we have to take into consideration. In the late 70s, Dr. Ronald Roth said, he was a famous American orthodontist, and he said that to avoid untoward sequel or post-orthodontic tooth movements and occlusal wear and temporomandibular joint disorders, the best thing that we have to obtain is occlusion free from centric and excursive interferences. And relapse is not only tooth movements that occur as have been the existing tooth movements, but relapse means that some new unwanted tooth movements can arise. Occlusion is the thing that supports the teeth through every one of their functions. And the way that we can perceive, that we can visualize occlusion is by using the articulation paper marks. But articulation paper marks can depict the overall picture of all the contacts, and they do not give us the opportunity to identify the role of a single contact on the tooth, on the mandibular movement. We can measure occlusion in three major dimensions. These are sagittal dimension, vertical, and transverse. But there is one more thing that we have to take into the consideration. We have to think about the fourth dimension of occlusion, which is time. And the time is the major contributor to orthodontic relapse.
Hello, I'm Svitlana Koval, orthodontist and experienced T-scan user. We used to treat our patients placing retainers after the completion of treatment. The retainers were aimed to maintain newly achieved tooth position. We did it again and again in every single patient.
A simple retainer not always can maintain proper tooth position. It happens so that upper anterior teeth can become rotated even with retainer in place. Occlusion and tooth contacts have a severe impact on teeth alignment. Moreover, contacts and excursive movements cause upper anterior teeth to rotate and tip buccally. T-scan occlusal analysis can measure the time of excursive contact that causes relapse. Orthodontics is a natural way to position teeth so that they function evenly. Natural tooth positions preserve their anatomy, which in turn makes the whole dentition balanced. T-scan occlusal analysis and DTR procedure can be used to stabilize occlusion after completion of treatment without retainers. Only nature.
We discovered the fourth dimension of occlusion for ourselves, the time. Our aim is to make orthodontic treatment more effective. Discover the nature in everything you do.
This was short film to familiarize you with the procedure of T-scan recording and how we manage this in our clinic, but this was a kind of a picture in the natural landscape. So I want to express my sincere gratitude to my mentor, Dr. Robert Kirstein-Didias, and to John Bradke, who gave me the opportunity to master the T-scan digital occlusal analysis procedure. And influenced by this procedure, we developed our own technique, the anterior-posterior tooth contact analysis, which helps us to minimize the number of unwanted tooth movements after the completion of orthodontic treatment. Our protocol is to measure and to analyze the number and distribution and the duration of contacts during the debonding stage, during the detailing stage of orthodontic treatment. So our aim is to decrease the so-called disclusion time, which is the time of the teeth being away from the maximum intercostal position to the anterior guidance position. So the average time of the disclusion time is about 0.5 seconds, and our aim is to achieve tooth position so that we have this disclusion time within this range. So we incorporated some modifications, we modified final tooth positions during the detailing stage so that to decrease this disclusion time. After that, we analyzed the occlusion once again, and we start being able to debond our patient to take off the fixed orthodontic implants. We do our follow-up appointments with the T-scan digital occlusal analysis in 1 month and in 3 months and in 6 months. So we follow up our patients during the year after the completion of orthodontic treatment. So our aim is to avoid the use of any type of upper retainer and to stabilize the upper arch so that we do not have any unwanted tooth movements and any relapse in the upper arch. Lateral intrusive movement is guided by the upper canine's lingual fossa, mesial lingual fossa, and is restricted by the lingual ridge of the upper canine. Here we see the picture with the paper marks with the use of the 8-micron articulation paper. And we consider it to be a group function when the disclusion time exceeds 0.5 seconds. And we accept 0.4 seconds and consider it to be a pure canine guidance only if we have this T-scan recording. We can see these paper marks here on the picture that include both centric contacts and excursive contacts, but in these patients, the excursive time, the disclusion time is less than 0.5 seconds. So this is a pure canine guidance. The anterior guidance on the other side is guided by the distal lingual fossa and restricted by the lingual ridge. And so we aim to have the same disclusion time of less than 0.5 seconds. Final canine position is achieved by orthodontic treatment and by we have an advantage with the use of orthodontic treatment to make the final canine position more precise. Canine disclusion is guided by the slopes of the mesial lingual fossa and by the lingual ridge, and the rotation, angulation, and inclination of the canine strongly influence the disclusion time. This is what we have, this is what we achieve with our clinical research and with our observations. So difference in the canine rotation, now you can see tooth number 11, and this canine is rotated distally out, and the canine guidance in this case will be guided not by the mesial lingual fossa, but by the mesial line angle, and we will have additional tooth contacts in the lateral segment, and the pure canine guidance will be deranged. So proper canine positioning places the mesial and distal lingual fossa into the proper position. And when we have these proper positions, we have the mandibular path being regulated. Canine extrusion with the orthodontic techniques and with the orthodontic methods can bring the canine fossas and the lingual ridge down, and this can this can decrease the disclusion time even more. Canine lingual anatomy. This is the summary of the P9's guidances, and we see that the mesolingual fossa guides the lateral intrusive movement, and the protrusion is guided by the distal lingual fossa. And these things can be influenced either by the orthopedic approach, this is the restorative approach, where we change the lingual anatomy, and it can be also managed by orthodontic means when we alter the tooth position itself. This is case one, just to illustrate our procedure and probable outcomes. And we see the patient during the detailing stage, and we see marked occlusal contacts here. What we do, we conduct T-scan digital occlusal analysis, and the average procedure contains 4 recordings. This is the centric occlusal recording and 3 excursive movements, lateral excursive movement right and protrusive movement. And what we see here, this is a print screen of the lateral guidance, and we see that we have an immediate intrusive contact on tooth number 2, and we have some contacts on teeth number 14 and 15, and there is a special time graph. I don't know whether it is clearly seen, but this is a time scale and the time measuring. This is the thing that we have to control. This is the disclusion time here. Unfortunately, it can't be clearly seen, but the disclusion time in this case is 1.1 seconds. It's about 2 times more than we have to expect, and so our aim during this stage is to alter tooth position so that we can decrease this disclusion time. So you see the paper marks here, they are all along the occlusal surface of tooth number 2. But what occlusal contact really contributes to this disclusion time? This can be only seen with the T-scan digital analysis. Although there are a lot of marks, and Dr. Kirstein has conducted research, and he has concluded that there is a negative correlation between the size of the paper mark and its and the force that is given by this paper mark, by this occlusal contact. And so the less is the size of the paper mark, the less is the size of the area of the contact, the more is the force. This is the same as with women's high heels, where a very high force is situated on a very small area. And so the medial intrusive contact on tooth number 2 contributes to the prolonged disclusion time in the left lateral intrusive movement. What we see here, that right lateral intrusive movement, this is the picture on the right upper corner. This is totally okay, and the disclusion time is 0.34 seconds. And after we have incorporated some movements, we still have the increased disclusion time here in left lateral intrusion. But after that, we incorporated more movements, and this is this patient during the debonding stage. You see that we placed a fixed lingual retainer on the lower arch and no upper retainer at all. So we have to check the occlusion once more, and after the debonding, we expect the patient to settle the occlusion. We expect more teeth to come into occlusion and more contacts to be distributed along the dental arches. But still, we make the analysis. We have the protrusion recording, right lateral intrusion, and the first picture is the picture of the left lateral intrusion. Although the time is significantly less, it's about 0.7 seconds, but still we have these medial intrusive contact on tooth number 2. And so this is the patient. This is this patient after 1 month. This is the 1 month follow-up, and what we see that this medial intrusive contact, this prolonged contact, cause the anterior teeth to tip buccally. This is what we expect when we have the prolonged disclusion time. The posterior contacts tend to push the mandible forward, and it attacks the upper teeth from the lingual side, tending these teeth to tip buccally and to rotate. And so here we see that tooth number 8 has been tipped buccally, and we have now to deal with the relapse, and we are incorporating the removable aligner just to close these teeth. Case number 2 is a success case when we measure the occlusion during the detailing stage, and what we measure here, we see that this is the central occlusal screen, and we see that the occlusal contacts are evenly distributed along the dental arches, and we have a lot of contacts, and they are very good, very well distributed. And the next 2 pictures are the left lateral and right lateral excursions, and what we see here that we have lateral working contacts in both cases, and the disclusion time is long, that we do not have a pure canine guidance. Left lateral excursion was, the disclusion time in left lateral excursion was increased significantly, and we tried to analyze why did it happen so. And we see that this patient was wearing class 2 elastics, and they were attached to the lower molars. And now we see that horizontal and vertical forces exhibited by the class 2 elastics tended to extrude the lower molars, and we see that the marginal ridges of tooth number 19 and tooth number 18 have the discrepancy in their vertical position, and so there is a marginal ridge height discrepancy, and which was caused by vertical forces. So now I'm finishing. So now we see that with the use of this analysis, we have a premature contact on the mesial marginal, the mesial line angle of tooth number 6, and this contact prevents the mandible from being finally positioned in a good occlusion. So we have to change the rotation of the canine to position the mandible properly. And what we see here that a lot of contacts are distributed along the occlusal surfaces, but not all of them are significant for us. We have to compare the occlusal taper marks with the T-scan data. And what we see here, this is the picture of this patient after debonding, and we expect this patient to settle the occlusion. And the main thing that we have to achieve with our treatment is the stability of the upper dental arch with no retainer at all. So we routinely use centric occlusal recording, protrusive movement, lateral excursion, and right lateral excursion. And this is the picture of the lingual view of this patient with no diastemas and no spacings, no rotations, which was achieved due to the proper use of the occlusal analysis and with no retainer at all. Thank you for your kind attention.